They say it's up to the river. And there's a report where we say we have what we call an alarming wetland loss. And we say around 48% of our wetlands and 25% of our, we have lost our water bodies by around 25% in a span of around 9 years. And we say that the main drivers for wetland loss is the agricultural expansion, food. We talk about the settlement, unsustainable land use, especially the mining. And what happens? It leads to water scarcity, biodiversity loss, and you have cases of increased flooding and droughts. You remember how they control our flooding. And we say if you have what we call degraded wetlands, it reduces food system resilience and local livelihood. Then we say you have this new policy which offers a framework for reversing these trends. And what are the policy and governance frameworks? We say Murang'a County Wetland Riparian Area Policy 2024 provides a legal framework for protection, restoration, and sustainable land use. It defines the buffer zones, it regulates encroachment, and promotes on how we are going to do the rehabilitation. You also at the national level, you look at what we call EMCA, that is Environmental and Management Coordination Act. As you understand, it has been revised to 2016. We are using the one for 2009, but we have the revised one for 2016, which prohibits unregulated activities in wetland and riparian areas, and also to provide backing for enforcement and compliance. Also, issues of wetland management, we have put it in our CIDP, that is County Integrated Development Plan 2023 to 2027. Also, the CASCOM, that is County Agriculture Sector Steering Committee. I'll talk about how they'll be managing. Then we have what you call the county-based MSPs. When you come to issues of wetlands, rehabilitation, and agroecology, you always have what you call the governance challenges. The first one is weak enforcement. How do we enforce? Is it the county which is going to do the enforcement? Is it the NEMA? Is it the RUAs? Or is it the Resource Water Users Associations? Low public awareness of environmental laws and regulations. You look at what you call the NEMA law. It's talk about 30 feet. You come to the surveyors. When they are surveying your land, they go up to the middle of the river. So which one are you going to use? Limited technical and financial capacity. You want to do the rehabilitation of those wetlands. Do you have that capacity? But when you do the budget, you require a lot of money on that. These days we are talking about data management. We say there's inadequate data systems. If you ask in your county, how many wetlands do you have? And are they protected? Also, you have poor coordination among agencies. Also, you have what you call conflicting land uses. In this, we are provided for, we need what you call science and data management. If you have to do what you call the wetland management, when you do, you're going to do what you call, you're going to look at what you call ecosystem health monitoring. Then if you want to do a lot of conservation, you have to use the community. That is what you call community-based monitoring. Then you look for what you call platform evidence-based decision making. Then we come to the main picture. How wetlands support agroecology? One, remember wetland riparian area, their source of water. We need to do what you call regulated irrigations. We need to do what we call crop water requirements. When you talk about irrigation, you talk about the three questions. When, how, and when, how. Then nutrient resource. The moment you protect those wetlands, remember when you're talking about agriculture, you talk about a principle called soil health. It's also here. Remember the wetlands, they are habitats for pollinators and pests, predators, if it's well maintained. Then you look at the agricultural practices that support wetlands. One, natural vegetation buffers. We need to have those natural vegetation buffers. And with your farm, you have what you call contour planting. If you are a livestock farmer, you do what you call rotational grazing and sustainable livestock management, organic composting, biochar, and the rest, and minimum chemical input near our wetlands. And we say, if you look at the agricultural practices, they reduce pressure on our wetland ecosystems. And what is the policy brief recommendations? I'm going to look at 3 people, that is the policy makers, the government agencies, NGOs and development partners, farmers and community. For the policy makers, we are calling on the policy maker to allocate funding for wetland restorations and the policy enforcement. 2, we set the coordination role of the CASCOM. And 3, we do what we call integrated wetland protection, interland use, and planning control. We have to include them in our planning. For government agencies, you enforce existing regulations and land use zoning laws. They are always neglected. You always have what you call physical planning, but you never use them. Then you need to do what you conduct regular public sensitizations and capacity building programs. Then we support what we call participatory monitoring and evaluations. What about the civil society and the NGOs? They provide the technical support and training to community groups, facilitate inclusive governance platform, and then they promote documentation and scaling of best practices. What about our farmers, who are our employers? They should respect what we call the wetland buffer zones and they avoid encroachment. 2, they adopt wetland-friendly ecological practices. And lastly, they participate in restoration and core management initiatives. And lastly, call to action and conclusion. We say Muranga wetlands, or generally wetlands in Kenya, are vital for biodiversity, water regulation, and food systems resilience. And they say our 2024 wetland policy provides a strong foundation for integrated conservation development. And we say success requires collaboration among policymakers, scientists, agencies, farmers, and communities. And future resilience depends on what we collectively do today to safeguard these ecosystems. Thank you.
Thank you very much, James, for that insightful presentation on the connectedness between wetlands and other systems in the farms. Our second presenter is going to be Mr. Crispas Kenywa on hospitals as frontline for agroecological transformation, reclaiming public institutions in food systems change. Karibu sana. I think we shall have the 2 presenters presenting, then we can ask a few questions. Karibu sana.
Hi everyone. We are very many. We are so many. Okay, thank you. My name is Crispas Kenywa, and it's really nice to be doing this presentation, and it's also good to see all of you. So my topic is hospitals as frontlines for agroecological transformation, reclaiming public institutions in food systems change. I know this is pretty new probably to many of us, but we all resonate with the issue of hospitals. And if you had not seen them before as institutions that should be involved in food systems transformation, I hope after this you will be able to see why. All right. So agroecology is a global imperative. I think all of us know that we are going through a lot of challenges with food systems, and I think this has been spoken of enough, especially during this forum. We are going through a climate crisis at the moment, and the connection with food systems is also very clear. one of the speakers yesterday talked about how we bring on board food from up country and then we dump it in our cities. You see that we see a lot of garbage in our cities, and this is releasing methane and contributing to a lot of climate, the greenhouse gases. The second one is malnutrition. That is where also nutrition comes in very, very strongly in food systems and agroecology. That we are going through a triple burden of malnutrition. So agroecology then promotes diverse cropping and preservation of traditional foods. So that photo here is traditional foods. And it is also AI generated, I should have said that. Traditional foods which have the potential to enhance dietary quality and combat malnutrition. But it's also important to note that growing food agroecologically, producing nutritious food, does not automatically relate to consumption of the same food. So we need to be very intentional about popularizing agroecologically grown foods, including now in the hospital sector. The other one is inequality, also very important, that food systems have been contributing a lot to inequality. And inequality is where there are some people benefiting from something and many others are not benefiting from the same. So for instance, this conversation around pesticides in this country, they benefit multinational corporations. They're building economies in the global north. But our consumers here are suffering from the challenges of the effects of pesticides. The same case with the issue of brokers and how they buy food very cheaply from farmers, and farmers are left to really struggle. So there's growing interest among farmers, researchers, advocates, but but focus of agroecology has mostly been farm-centric and farmer-oriented. There has been minimal focus on institutions, and we haven't been seeing institutions as centers of agroecological practice and also for food systems transformation. Why do hospitals matter in food systems? Number one, hospitals provide institutional demand, high institutional demand. So hospitals are institutions. They're part of public institutions, whereby there are people there who are not feeling well and they need very specific food. They need to be fed every day, every now and then. So they provide institutional demand. And in as much as this is a new issue, we know there has been a lot of attention on school feeding, especially in terms of food systems. So this conversation on hospitals is also not very new as institutions. The second reason why hospitals matter in food systems is that patients need specialized diets. We have hospitals seeing very different cases, from surgery to trauma to ICU, renal, diabetes, and many others, basically. All sorts of illnesses that we know in this country. So patients need specialized diets. Agroecology is promoting what? Biodiversity, inequally. And biodiversity means that we are producing food so that we can also consume. So this is a ready market already. It's a ready market that as our smallholders are producing those different various crops, they have a ready market in the hospitals. The other reason why hospitals matter is because of a very important issue called underdeveloped nutraceutical industry. Nutraceutical means the industry, just like pharmaceutical. Now this one deals with nutraceuticals, nutrition products. I think very, very few products, nutrition supplements, are produced in Kenya. Actually, even in Africa. And I'm going to probably mention a few, like in as much as it's not a very relevant example, baby formula, where does it come from? Baby formula, the baby, ile maziwa ya nan, what you call nan. Yes, many of those are from, and it's not even, we can call it a supplement for this case, but what many people don't know is that many supplements that you find in hospitals are very expensive. They are imported, and they are also, let me just repeat that, they are very expensive for patients. So our nutraceutical industry is underdeveloped. But now what we are seeing again with agroecology is that farmers are getting towards value addition. Like if you have gone around, you've seen, like now I could give a shout out to CSHEP because we are working with them. It's doing a good job. CSHEP is doing a good job because now it's bringing farmers together who are doing value addition on different products that can now be used even in the healthcare sector. A lot of those products, if they are done right, they go through the right certifications, can be used very well in the industry. The other reason is that there's need for affordable, local, value-added agroecological products. The other reason is poor food quality and safety oversight. Poor food quality and safety oversight. The reason why hospitals matter in food systems. Now, procurement systems of hospitals are very opaque. You know how tenders are given in this country. You know the tenderpreneurs and all that business. So when someone has been given a tender to procure food for the hospital, there is very minimal oversight in terms of the food safety aspects. And so when a patient is admitted in the hospital, there's no guarantee that the food they're eating is going to be safe. And you know we have a problem with food safety hazards in this country, food safety, be it aflatoxins, be it heavy metals, be it pesticide residues, a very big battle that has been going on in this country, especially led by and championed by the civil society. So there is need for this to be addressed, the issue of food safety oversight, yeah, and also the issue of quality. So we need regulations to be enforced in terms of how food is procured. And lastly, why hospitals matter is because they should be sites of healing and nourishment, not malnutrition. Maybe if you're still floating, what my presentation aims to say is that our hospitals are not doing well enough in terms of providing quality food to patients. And you find that sometimes patients get malnourished when they are in hospital, and sometimes they get to the extent of even dying or staying so long in the hospital because of the quality of food. And it's a problem across many public institutions. And I like asking people how their high school food was, because how your high school food was is how public hospitals are. I don't know how your high school food was, but mine was not very good. And I think that many people have met the school food was not very good. And again, it's also another neglected area, but we shall discuss that another time. So we are currently doing advocacy work in Thika Level 5 as IFJAD. I didn't even introduce myself. Crispus Kenywa, and I'm the founder of IFJAD and director. And IFJAD is a non-profit that we are working at the intersection of food justice and development, social economic development for food workers. So the food justice movement seeks to promote or champion the right to food, but also the welfare of food workers, and also alongside other injustices in food systems. Because if you look at our food systems, you tend to see a lot of injustices, inequalities, unfairness, whether it's at the farmer level, the seed level, all those issues of GMOs being forced down at the throats of farmers, to the consumer level, the issue of food adulteration and whatnot. So the food justice approach looks at justice aspects in foods. And so IFJAD as a non-profit is trying to promote that, or rather to tackle those injustices, systemic injustices in food systems. So we are doing a project in Thika Level 5, which is a public hospital in Kiambu County. And we are calling it a multi-stakeholder approach, because we are involving different stakeholders who are responsible for hospital meals. And we started this project sometime back in November, this advocacy project, and it's also ongoing. It's ongoing. And so what steps have we taken so far? If you look here, the step one is that when we started this work, we started with the question: what is the problem with hospital meals? Why are they so bad? Why are patients eating ugali, cabbage, and beans and soup? What exactly is the problem? And so we sat down together with the stakeholders, who include now what we call the catering committee of a hospital. And this committee is made up of different departments, including the nutrition department, the finance department, the procurement department, public health, and there was that brainstorming. The good thing is that the nutrition department already felt there's a problem, and this is the case across all countries, all counties where hospitals have a challenge with feeding the patients. The nutrition departments in those have a sense of helplessness because of the factors that predispose them to this, to be like this. And so one of the things that we identified was the absence of a dedicated food budget So you see a patient would go to a hospital, they are charged for procedures, they are charged for everything that they are charged. In as much as little, they are still charged. But when it comes to food, there lacks a way of charging patients for food. So they are eating for free. And you see, when that is happening, that brings out an issue of sustainability. It is not sustainable to feed people for free. And this happened because of devolution. Before devolution, hospitals were feeding patients well because all this money would come from the national government. But after devolution, that meant that hospitals and counties were responsible for feeding the patients. And so that has never happened quite well. So one of those things we saw was that they lacked a dedicated budget for patients. That is why they were eating that very nasty food. The second reason we saw, or the second problem we saw, that of course the food was nutritionally inadequate. There is a way in which patients are supposed to be fed depending on the condition that has brought this patient in a hospital. Yeah. So someone who has a surgical issue should not be fed the same way as someone with anemia, should not be fed the same as a person with burns or whatever issues they have. But then the meal, they are often given one type of meal in many hospitals, and in Thika level 5 it was still the case. And so that was very well noted. The other one was the lack of administrative support to the nutrition department. This could be a bit controversial, but because I'm a food advocate or food activist, I think it's just okay. But as nutritionists, we feel that governments, generally, even the national government, county governments, don't support the profession really well in terms of everything, really. Because now if you look at how the food is served, for instance, if you look at how nutrition interns are not hired, just last 2 weeks ago, we saw a long list of medical cadres being hired to be interns. But one of the very glaringly missing was nutrition. And yet, in every of these specialties in hospital, a nutritionist is needed to feed the patient to recovery. So lack of support, I think, has been one of a big challenge. And also another one is a lack of policies to guide food procurement and food preparation in hospitals. Policies are lacking that should guide these processes. So then the second step was now designing reform, collaborative approach, and we participated in like 3 meetings with them, different meetings, again with these conversations. And there were some agreements that we came up with, and through joint planning sessions, the team developed practical hospital-led solutions because the hospital was the one leading this process. And they introduced a modest daily food charge of 300 shillings per patient per day, ensuring the process was accountable, inclusive, and focused on improving patient care. So this issue of money brings, issues of money brings many problems. But I've got to remind you that before, patients were eating very bad food and patients were dying because of lack of good food, right? And that patients were also being charged for everything else except for food. So introducing a modest fee of 300 shillings that will now include proteins and animal proteins, which were mainly lacking, fruits and vegetables. I think 300 shillings was a fair price. And then the third process was implementing the change, which included now that innovative financing in action. That the reform has been implemented already, and they are working towards now having that SHA to cover that. I believe it's covering that SHA, so patients don't have to pay extra for that. And it has potential to generate 3.5 million shillings per month for the hospital, for the department, for the nutrition department. And this will strengthen kitchen staffing, it will strengthen improving meal quality, it will strengthen establishing a hospital kitchen garden for fresh chemical-free produce. Challenges still remain, but progress is underway. Challenges remain because of sustainability aspects. Again, administrative support sometimes, because of new leadership, sometimes these changes can be reverted, and also because of political reasons. So hospitals as gateway for agroecological impacts. Beyond being places for medical treatment, they can serve as important entry points or catalysts for promoting agroecology within the broader food system. They can actively source food produced through agroecological practices, and this is sustainable food, chemical-free food, produced through local farming, and food that prioritizes smallholder farmers, especially women and youth. So women and youth need to be prioritized, smallholder farmers, practicing agroecology into the procurement systems of these hospitals. The other one is that the hospitals influence demand for healthy, safe, environmentally friendly food. All these things we are saying that we need to produce food for, hospitals need that. Hence the need to bring agroecology advocacy into hospitals, because there's already demand for those foods that we are saying. The other reason is hospitals can become models of sustainable food procurement and nutrition care. Hospitals can become good models for that. The other one is that they can help connect vulnerable patients to better, more nutritious food that supports healing, and lastly, serve as visible public institutions leading change in food systems. Now, hospitals are just part of public institutions that need change in terms of food systems. I just asked you about your high school food, but I don't know if you know, but prisons also need reforms in terms of food quality. Have you seen prison food? Do prisoners deserve good quality food? Do they? They are being punished. What about those in remand, those who might be innocent, because they also eat the same food? They issues of equality. Prisoners, you know, there's this thing called the right to food. A right to food means that you have a right to safe, nutritious, affordable food despite anything, on the basis of you being human, regardless of your nationality, regardless of your color, regardless of anything. So prisoners also deserve good food in as much as they are being punished. I actually think that the prison system should have leanings of rehabilitation more than punishment, so that they can fix these people who are doing bad things in this country. So again, also NYS colleges, if you go and look at the kind of food they eat, it's really nasty. No one talks about it. Police training also, again, universities, colleges, public institutions need to be involved in this dialogue on food systems change. Not just hospitals, but basically public institutions. And I just believe that hospitals should be the ones leading on this conversation, because of how important good food is to the hospitals. That when a patient can be in the ICU, given good food they recover, or given neglected and they die for avoidable reasons. So conclusion, county public hospitals present underutilized institutional leverage points for agroecological transformation, as we have seen already. They are underutilized. I should have also mentioned that a lot of hospitals have land that can grow kitchen gardens, that can grow, that can also offer agroforestry. Okay, so a lot of potential is there, but they are underutilized. Yeah. Integrating agroecology into hospital food systems enhances patient recovery, enhances food safety and service quality. Again, brings out issues of dignity there. As a food justice advocate, I believe that one of the reasons we are not very keen on the quality of food that we feed to the public is because of the issue of dignity. We don't value ourselves well enough. The reason why we used to hear that kerosene was added to the githeri in high school, and whether or not it was true, that those are issues of dignity. I think everybody believes that kerosene was added. I have not confirmed that factually, but I think issues of dignity. And in the food justice world, one of the themes that we see a lot is something called disproportionate suffering of people more than others. Like now, the black race has suffered disproportionately from food systems than other races. From the origins of food justice movement in America, the times of the uprising against racism and slavery, because of punitive policies that were being forced upon these black people. To date, the African race struggles a lot in America and the developed world because of in the food systems. For instance, in nutrition, we study that in America, for instance, majority of the people with diabetes and hypertension are what? What race? Black. Africans are the ones leading in non-communicable diseases in America. Okay, so and then we go to the reasons. Why does this happen? And you see that it's because access to food is a challenge for them more than the white people. Unlike here where they have abundance everywhere, including very near your plot. If you live like the rest of us, not those who live in the suburbs, there's a kibanda there. But there you will have to drive a distance to a very nice grocery shop. They call them grocery shops. In the black communities, grocery shops are few or expensive and out of reach for them. So they could be there, but financially they can't afford, because their managu costs, what do we say, a foot, an arm and a leg, or what? An arm and a foot. Very expensive. And there now the junk food is cheaper. So for the African communities, that's why it's promoting these problems, that healthy food is not easily accessible and junk food is very easily accessible. So even in Kenya, we still have some of those colonial legacies of food systems, that we have been abandoning our food systems, the traditional food systems, including the traditional foods, the whole meals, the millets, and nowadays we are calling them the forgotten foods, which is really weird. And we are embracing the super refined foods. Like if you watch your TV station tonight, you will see a lot of ungas being advertised, very refined, premium, whatever. And these things are not even nutritious, and they are promoting non-communicable diseases. So we need to look at issues of I was just trying to insist on this issue of dignity in food systems and how Africans have suffered because of the same. Thirdly, FICA Level 5 hospital experience illustrates the viability of participatory resource-sensitive reforms. This project has not been done with a lot of resources, and we will be reaching out to funders and donors and trying to convince them why they should fund hospitals and these things of food systems in hospitals, because there is need for resources in healthcare systems, and integrating now agroecology in it. So resources have been strained, and but we've been able to achieve quite something. So I believe with more resources, we will be able to do much more. And then strategic linkages between health systems and agroecological producers can reinforce local economies and climate resilience. Strategic linkages between health systems and agroecological producers, smallholder farmers around those hospitals. If there's that good linkages, it will reinforce local economies. They will make some money from it, and it will also promote climate resilience. Lastly, institutional procurement reform is essential for scaling equitable, sustainable food systems from the ground up. And what is the way forward? That county governments should integrate agroecological criteria into hospital procurement frameworks and allocate dedicated nutrition budgets, prioritize nutrition, integrate agroecology in hospital procurement frameworks. Secondly, health and agriculture ministries, they should develop intersectoral policies promoting agroecology or agroecological food environments in public institutions. I was so happy to hear the Makueni CEC say that since she's moving to the health department, she will champion that hospitals source agroecologically produced foods. Then hospital administrators should institutionalize multi-stakeholder food committees and pilot kitchen gardens or local sourcing models in hospitals. And then second, from last, civil society and academia support implementation through technical assistance, monitoring and policy advocacy. Support implementation through technical assistance, monitoring and policy advocacy. Probably I could also add that issue now of funding. You know, in as much as donors are pulling out, we still need them so that they can, or probably now we need to look at local domestic philanthropy. Yeah. And lastly, national stakeholders should position hospitals as demonstration sites in agroecology, agroecology strategies, and right to food frameworks. And that is the end. Thank you for listening.
Asante, keti hapa kwa sababu ya media. Yeah, that's very insightful, and he has reminded us about the food we used to eat in high school. And apparently, in my family, we are 7 sisters and 4 brothers. And when almost all of us were in high school, the ladies would come back home very healthy and looking good. And we would always tell them that you ate more bruchids, more weevils than we did. So the quality of food also matters, and that's a good step according to me. So we want to have a few questions for the panelists, so that if there is any point you need clarified, if I can start on the food for hospitals. I think it is important that we are looking at the nutrition. And I like the idea that if it is possible that they produce their own food in the land that is not being used, that is also going to make sure that the food they produce is also chemical free, because you may have a lot of very good food, but it is full of chemicals. And you agree with me that the food we are eating, we are not sure. Even the one that we have eaten today, we were very happy, and it looked nice. But the type of chemicals that are being used in the farms, we cause for a lot of concern. So if we can now try to tell them to, or we introduce policies that will make sure that in hospitals there are systems where the capacity development you have talked about will include systems that will minimize or remove, like the chemicals, like the issue of proper cleaning of the food that we have in the hospitals. That is going to help. I think I want to edit that. Any comment, any question? No, I don't. It's okay.
because the food or how they understood food intake, they were not able to get the food that I recommended as a nutrition.
Thank you. Any other question or comment? Yeah.
Yeah, my question goes to the last presenter. First and foremost, thank you for the very good presentation and the very insightful comments that were in your presentation. I'm aware that across Kenya today we have what we call the CNAPs, the County Nutrition Action Plans. I don't know, as you've been going about your work, have you taken time to interrogate the CNAPs and to see whether they speak to anything with regard to hospital meals and even school feeding programs? And whether they do speak to it or not, do you see that that could be an opportunity for us to maybe pursue that particular direction and see to it that we give our patients good food so that we remove the need for them to take in more medicines? Because I believe the moment people are able to eat good food, the rates of recovery will be much faster, and they'll be much stronger, and they'll need less medicine if at all they're getting good food, and if again that of course can be replicated back at home when they leave hospital. And for my colleague, my friend from the government side, you made a very honest observation regarding the disconnect between our public surveyors, both public and private surveyors, and what the law says, particularly when it comes to management of wetlands. The Environmental Management and Coordination Act, EMCA, is so clear. Over and above that, we have had resolutions coming from NEMA, which are also very clear with regard to just how far can you till. My sister has come up with a question that is almost alluding to the same, but I wanted to know, is it possible using different county government structures and even national government structures and policies for that matter to be able to enforce the policies and the rules that prevent people from cultivating in the wetlands, but give them opportunity to still benefit from the wetland by engaging in economic activities that are nature-based? Like, for instance, instead of digging up the area to plant maybe wheat or rice or maize or whatever it is, we could still place, beehives in those areas, and we could harvest honey, and we could get an income that is even over and above what we could have gotten from what we are striving to get, and we get so little even after damaging the entire environment. Thank you so much.
Hey, this is what we are doing for the last 3 months. What we did, we are supported by PERAM to develop that what we call riparian and wetland policy. And what we did, we are left with some funds, allowed 600,000. And what we have done, we are going to the community themselves, and you are conducting what we call conservation community. We are doing what we call conservation community action plan. It's like the way you do the PRI process, participatory rural appraisals. You go to the community, you hold what you call, you are holding with them what you call the dialogues. You are involving the rulers, the chiefs, and the university. And we have started with one dam called Marira Dam, and another one called Kiahiti. And the farthest thing, when we went to the one in Kiahiti, there's the river Sabasaba there, and they are cultivating what we call the French beans up to the river point. And with the French beans, you use a lot of chemicals. And you can imagine the amount of chemical people downstream they are consuming. So we went with them and we calculated what what you need to do. You need to talk to the community. Sometimes you do what you call you look at the business aspect. There are some people who are doing some arrow roots there, some fresh beans. Others, their dumps are maize in their plots, and some of their public lands. So what we did, I did some gross margins for maize. And the funny thing, in that quarter of land, they were getting around $5. And when we did our calculations, they are using more than 40,000 Kenya shillings to produce those $5. And $5 with the MOU I've done with the Kabagara and the rest, because Muranga, we are doing a lot of MOU with the maize processor under the Inua Mkulima. We are giving 4,000. 4,000 times $5, 20. And yet they spent 20. And the funny thing, and I did it purposely, you are not calculating the man days. I did it purposely. I did not calculate the man days. They were not paying themselves, and the labor they are using for their children, and also maybe the manure they are getting from their farms. And at the end of the day, I told them, we need to look at the bigger picture. Remember, you don't look at what you call, we never look, if you don't use that chemicals, or if you do solid water conservation in your farm, what future benefit do you have? Let's look at the water quality, the air quality, and the rest. Are you costing those? So what you are doing, I've made them like 3 times, and we are doing what we call the advocacy. Remember these days when you come to the county level, these are politicians, and they are looking for votes. Because I remember in one event, I invited the MCA. You have a very supportive lady, a nominated MCA who is the head of the County Assembly Environmental Committee, and he convinced his counterparts, especially the one in the malaria, the one in the university where there's School of Agriculture. They were doing a lot of quarrying, and the quarry dust, it was being taken downstream to them. And you know what we did? We went there with the NEMA people, and we talked to the community, and we had what we call a discussion. And they agreed, everybody is wrong. There are some people who are downstream, they were complaining about that dust. Also, they were not supposed even to cultivate. They are not respecting the 30 feet rule. So what we agreed, it's not a must we go to the 30 feet or the 10-meter rule. We can come up to 3 meters. We open up that one. If it's for the quarry, they have to start mitigating, to come up with mitigating issues. So for what we are supposed to plant there, what we are doing, we are looking for what we call alternative livelihood. And we talked about the dairy goats, the rabbits. And you know, there are some enterprises which are neglected, but they bring a lot of money. The dairy goats, a liter of milk, it will go for a hand. Nutrition is how much? 200 or 250. You go to the yogurt, you do some of the value addition. And in fact, as early as last week, they were calling me. They were telling me, already you have formed what you call a CBO. They have registered with social services because they want to take advantage of the FROCA. Because I was also telling them, you can also do what you call indigenous trees, because you want to plant what you call environmental friendly trees in those river things. Also, you have to plant what you call the grasses. So that is the way you go about it. Because if you try to go the hard way, to use those instruments, remember you are working on the also political side, the MCAs, anataka kura huko, the governor. So what you do, you look at what we call win-win situations. Thank you. I hope I have answered your question then.
All right, thank you for the questions. I'm going to start with the question by Jessica about how we can make these meals as bioavailable as possible for patients, for them to recover. And it's a very relevant question because, like I had earlier said in my presentation, that a lot of patients in hospitals require modified foods because for some, their digestive systems are not working as normal as the others. And so they require food to be processed in a way or to be made in a way that will make them easier. And with nutrition, there is training for all that, and there are provisions for all that. Types of foods, some could be liquid food or whatever it is. And this presents, again, an opportunity. For patients who are not able to feed well and they require those specialized foods, we usually give them those expensive supplements that I had said are imported, and they are really expensive. So what opportunity is there for agroecology is that we will now give these patients supplements that have been made locally by farmers and the youth who are doing value addition. Something as simple as a juice from a herbal juice or a herbal drink can be very good for patients recovering from surgery, like the abdominal surgeries and so on. So really, it's a matter of modifying the foods to make sure that they are going to help the patients. The other question by my friend Mswahili, he asked about the county policies. We are in the process of reviewing those policies so that we see what they offer. But for hospitals, I think there are policies that are very, very specific to guide how meals are implemented that may not be covered by the county, by the synapse, because those are what we call protocols, inpatient feeding protocols. At the national level, they are being developed. It has taken quite some time, but they are still far from being developed. There's also another policy on procurement that guides how food is procured for hospitals. So these two policies, I think, will be more relevant, and we can pursue them and helping counties to developing these policies so that the patients can be well taken care of in terms of the food sector. Thank you.
Asante sana. You'll agree with me that the discussion has been good. And I just want to compare the people who went to the other sessions with those people who go for Kafagara and they believe the real food, because we have learned a lot about this, and it is a very good initiative. The issue of the wetlands, we are using land which is not ours, and I will tell you that I have been a victim of that. I have a demonstration center in Ruiru, and I had cultivated up to hata nawambia igieni kabisa fuko. And you know, see, this is Ruiru River. Then when it was raining last year, and I lost seedlings worth over 3 million because of my because of what he is talking about. So I think we have learned a lot, and I think we need to all of us work together. And for us, we have realized that in schools there is also that problem, that nutrition problem. So what we are doing is we are giving teachers please avocado seedlings, and we tell them that they should be planted where the children can get access. Let the children steal those avocados and go and eat in their dormitories, but at least they have something. So it is something that we are working on. We are also introducing through the school feeding program in Murang'a, the issue of kitchen gardening, so that the schools can be able to grow their own food. And then we dictate what type of food should be grown. So I would like to thank you very much for coming to this session, and we hope to interact more in the future. Thank you very much. What is each, if Jad, can you repeat what the Jad, just
okay, it stands for the Institute for Food Justice and Development. Yeah. Institute for Food Justice and Development. Yeah.
Thank you very much. Tumemaliza.